Yep, so the contents would be vestibulocochlear nerve, vagus nerve, accessory nerve, hypoglossal nerve. So start off with vestibulocochlear nerve. So it comes off the brainstem at the cerebellopontine angle. The other nerve, I think, is facial nerve, that comes from the same area. It goes through the internal acoustic meatus, and within the internal acoustic meatus, the vestibulocochlear nerve splits into its two components. So you've got the vestibular nerve and the cochlear nerve. The cochlear nerve supplies the organ of Corti, and the vestibular nerve supplies the utricle, saccule, and the three semicircular canals.
Meanwhile, the spectators are wondering if there'll be stormy waters.
Can we mute our sound, please? Thank you. So, just going over a bit about hearing and the nerves. So yeah, this is just the anatomy of the ear, the external auditory canal, the tympanic membrane. You've got these three ossicles, and then you've got stapes where it attaches to the oval window. Got the cochlea, and then you've got your round window, and then you've got your semicircular canals. So middle ear, external ear, you've got your eustachian tube. So the transmission of sound. So sound vibrates, it causes the tympanic membrane to vibrate. It's transmitted via the ossicles, and the stapes is pushed backwards and forwards against the oval window, setting vibration in the scala vestibuli. And then this vibration travels via the perilymph and the scala vestibuli and to the scala tympani, and this causes the vibration of the basilar membrane. And this is what makes the nerve impulse. There's another diagram of that. You've got your scala, you've got your oval window, goes into the scala vestibuli, goes down the scala tympani, you've got your organ of Corti and the basilar membrane, round window, the basilar membrane vibrates, causes a nerve to be traveled down the cochlear. Yep. And there you go, you've got the scala vestibuli at the top. You've got your scala, which contains perilymph, and the scala tympani at the bottom, which also contains perilymph. And then you've got scala media, or also known as the cochlear duct, which actually contains the endolymph. The oval window separates the middle ear from the scala vestibuli, and the round window separates the scala tympani from the middle ear. And again, the diagram, the bony labyrinth contains the perilymph, and you've got the membranous labyrinth, which contains the endolymph. I'm not going to go over the semicircular canals because, I mean, even I struggle to get my head around those, if you pardon the pun. But yep, you've got your semicircular canals, you've got your utricle and saccule. So just going over the test for the cranial nerve, vestibulocochlear nerve. So you've got the two tests, the Rinne's and Weber's test. You know, it's really hard to get your head around them if you don't use them regularly, and they can get confusing. So just to cover it, so you've got the Weber's test. The Weber's test, I think of the W as like a fringe, and you put the Weber's test is the one where you put the tuning fork on the forehead, and it basically you tune it, put it on the forehead, and you ask the patient if it lateralizes to a particular ear. Now, it doesn't tell you whether there's sensorineural or conductive deafness, but if it lateralizes, then you know that there's either conductive deafness in the ear that it's lateralized to, or the other ear has sensorineural deafness. Now, to see whether it's conductive or sensorineural deafness, you then have to do Rinne's test. Rinne's test is when you twang the tuning fork, you put it on the mastoid, and you test for bone conduction versus air conduction. And normally in a positive test, a positive is a healthy, normal test, air conduction should be louder than bone conduction. Whereas if there's conductive deafness, then bone conduction is actually louder than air conduction, because then the vibration in conductive deafness isn't traveling the normal way like we covered earlier. It's actually traveling via the bone, the temporal bone. So therefore there'll be something wrong, like a foreign object there, or perforation of the tympanic membrane, or otosclerosis, so damage to the ossicles, etc. So there's some sort of damage in the conductive part of the hearing, and therefore the bone conduction is actually louder than the air conduction. And again, that makes sense with Weber's test, because the sound travels better via the bone and not the normal way. Therefore, it lateralizes to the ear with conductive deafness. So that's Rinne's and Weber's test. And again, one thing to be aware of: acoustic neuromas or vestibular schwannomas, which is a tumor of the Schwann cells of the vestibular nerve. The patients can present with unilateral sensorineural hearing loss, tinnitus, vertigo, and again can get a facial nerve palsy because of the pressure on the facial nerve, because they both, remember, come off the cerebropontine angle. Now, going over the vagus nerve. So the vagus nerve is one of the longer nerves. Looking at this diagram, the rootless attached just lateral to the olives, just inferior or caudal to the glossopharyngeal nerve. So it's lateral to the olives, whereas the facial nerve and the vestibulocochlear nerve come off the cerebropontine angle. But then the glossopharyngeal nerve and vagus nerve come just lateral to the olives. You've got the pyramids in the middle, then you've got olives, and then you've got your vagus nerve and glossopharyngeal nerve. So vagus nerve has three functions. There's afferent functions. The afferent functions do sensation from the pharynx, larynx, esophagus, tympanic membrane, and external auditory meatus. And then it's also got these special chemoreceptors, the aortic body, and baroreceptors, the aortic arch. And again, it supplies sensation on the thoracic and abdominal viscera. The motor function, so again, the muscles of the soft palate, pharynx, larynx, and upper part of the esophagus. And however, just to bear in mind, the stylopharyngeus muscle, when we covered last week, is supplied by the glossopharyngeal nerve. And this is the vagus nerve is also involved in the gag reflex. So the sensory part is from the glossopharyngeal nerve, and then the motor part is from the vagus nerve. And again, parasympathetic, so smooth muscles, contraction of the GI tract, trachea, bronchi, and also supplies the heart rate, the heart. So the vagus nerve, it's an interesting nerve. It's quite a long nerve. It's got a few branches. So there's branches to the auricular branch. It's got the pharyngeal branch, and then you've got your superior laryngeal branch, the nerve. And that splits up into internal and external laryngeal nerve. And then you've got your recurrent laryngeal nerve. And then you've got your sinus nerve. So just going over the anatomy of the recurrent laryngeal nerve. So on the right side, as you can see, the right side has got this brachiocephalic artery, and it comes off, and the recurrent laryngeal nerve loops around the right subclavian artery, whereas if you look on the left side, it loops around the arch of the aorta. And that's the anatomy of the recurrent. So just going over the course, so like I say, it leaves a jugular foramen, comes out through the jugular foramen with the glossopharyngeal nerve and accessory nerve. It gives off the auricular branch, which supplies sensation to the external auditory canal and external ear. In the neck, it travels in the carotid sheath, along with a common carotid artery and internal jugular vein. Gives off the pharyngeal branch. The pharyngeal branch, again, you might see it with the glossopharyngeal nerve, also gives off the nerves in the pharyngeal branch, and it innervates the pharynx and soft palate. And then you've got your superior laryngeal nerve, which splits into two. You've got the external branch, which supplies the cricothyroid muscle. So the superior laryngeal nerve supplies the cricothyroid muscle. And then the internal branch supplies sensory to the laryngopharynx and the superior part of the larynx. And then you've got your recurrent laryngeal nerve, which supplies all the other intrinsic muscles of the larynx. So just remember, the intrinsic muscles of the larynx, the superior laryngeal nerve supplies the cricothyroid muscle, whereas all the other muscles are supplied by the recurrent laryngeal nerve. And then the parasympathetic innervation heart, the sinoatrial node and the atrioventricular node. And again, this is why when you have patients who have heart transplants, because the vagus nerve is ripped off the heart, when you have a heart transplant, they tend to have a bit of a higher heart rate. Smooth muscle contraction of the esophagus, and also it increases acid production increases rate of gastric emptying and acid production, and therefore previously for patients who had acid reflux and things, and one of the treatment was a vagotomy. The vagus nerve increases the acid production. We don't do that anymore. And then again, the carotid clinically, so the carotid sinus, when someone is in SVT, so narrow complex tachycardia, one thing we can do is we can do a carotid massage, and this gives a sensation of high blood pressure, and this increases the firing of the vagus nerve to cause a drop in the blood pressure and heart rate. And this can cause, again, it can cause syncope, but again, we can use it in someone with a narrow complex tachycardia, SVT. And again, damage to the recurrent laryngeal nerve during surgery or cancer invasion can cause dysphonia, and bilateral damage to the recurrent laryngeal nerve can cause inspiratory stridor. So, yep. And just going over the uvula. So the uvula is supplied by the vagus nerve, and normally when we test for vagus nerve damage, we look at deviation of the uvula. Now, classically, we've got this nucleus ambiguous, and then it synapses there, and then you get supply the lower motor neurons, which supply the uvula. Now, depending where the damage is, the uvula deviates. So, classically, in a lower motor neuron lesion, so lesion of the nucleus ambiguous or the nerve, what we get is the uvula deviates towards the healthy side. So the damaged area is no longer working, so the other side, the muscles are working, so it pulls the uvula towards it, so the uvula deviates away from the side of the lesion, as you can see in the diagram. Whereas an upper motor neuron, because it crosses over, the uvula will deviate towards the side of the lesion because of the crossovers to the contralateral side. So upper motor neuron lesion towards upper motor neuron lesion, the uvula deviates towards the lesion, whereas a lower motor neuron lesion, it deviates away from the lesion. I hope that makes sense. And then going over the accessory nerve. So like I say, the accessory nerve comes off, like I say, just below the vagus nerve and the glossopharyngeal nerve. It's got the cranial part and the spinal part. The spinal part goes up through the foramen magnum and comes out through the jugular foramen, along with the internal jugular vein, glossopharyngeal nerve, and the vagus nerve. So the cranial part emerges from lateral aspects of medulla oblongata, caudal to the vagus nerve, and it exits the jugular foramen and with the vagus nerve. The spinal part, the motor neuron located in the ventral grey matter and levels of the C1, C5, enters the cranial cavity through the foramen magnum and then supplies the sternocleidomastoid and trapezius muscle. And these are things we test in a accessory nerve. So we test the neck movement, sternocleidomastoid and trapezius. And because this nerve is quite superficial, the accessory nerve, it's prone to damage when we put central lines in or when we do cervical lymph node biopsies. Hypoglossal nerve. So the hypoglossal nerve, as you can see, it actually emerges in between the pyramids and the olives. So it's more medial than the glossopharyngeal vagus nerve, which are lateral to the olives. This one is in between the pyramids and olives. So this one supplies all the intrinsic and extrinsic muscles of the tongue, except for palatoglossus muscle, which is the vagus nerve, and causes tongue deviation. So again, upper motor neuron lesion, the tongue deviates towards the contralateral side. So if you can imagine, upper motor neuron lesion crosses over. If this side of the tongue muscle is working, it will push the tongue onto the other side. So if it's upper motor neuron, the tongue will deviate to the contralateral side because it crosses over. I've got a better picture in a second. Lower motor neuron lesion deviates to the ipsilateral side. And because this happens because of the overactivity of the genioglossus muscle. So here's a diagram to explain that a bit better. So weakness on the right side, the genioglossus muscle causes the left genioglossus muscle to push the tongue to the weak side. So as you can see, the right side's weak, so it pushes toward the left side. The muscle's working, so it pushes the tongue to the side. Another way of remembering it is you lick your wounds, so it will deviate towards the lesion. Now, upper motor neuron lesion is the other way, and the tongue deviates to the other side of the lesion. And then just to go over pseudobulbar palsy and bulbar palsy, because they're things that we often get confused. So a pseudobulbar palsy is an upper motor neuron lesion, and it affects the bulbar tracts of those cranial nerves listed there, whereas a bulbar palsy is a lower motor neuron lesion, and that's when you have a lesion in the nuclei of these cranial nerves. So bulbar is pseudobulbar affects the bulbar tracts, and it is an upper motor neuron lesion. Pseudobulbar is a lower motor neuron lesion. And the upper motor neuron, so pseudobulbar palsy, you get because it's an upper motor neuron lesion, you get exaggerated gag reflex, exaggerated jaw reflex, you get a spastic tongue, and this classic thing can give a spastic speech, which we call hot potato voice, and they get emotional lability. Whereas in a lower motor neuron lesion of the bulbar nuclei, you get absent gag reflex, you get a wasted tongue with fasciculations. So classically, they say it looks like a bag of worms. If it's a unilateral lesion, then what we get a raspy voice, whereas a bilateral lesion will cause a nasal voice.